hear me up there or wherever you are?
Yes.
Very good. Well, good to see everybody. I will call to order this meeting of the statewide substance use response working group for July 12, 2023 here at 2 p.m. And I'll ask that we do a roll call to establish quorum.
All right, Chelsea Cheatham. Dr. Dixon.
Here.
Senator Doniate. Gina Flores O'Toole. Attorney General Ford.
Here.
Senator Severs Gansert. Assemblywoman Hardy. Shayla Holmes.
Present.
Jeffrey Iverson. Jessica Johnson.
Present.
Lisa Lee. Debbie Nadler.
Present.
Angela Nichols. Christine Payson. Eric Schoen. Steve Shell.
Here.
Assemblywoman Thomas. Dr. Woodard.
Here.
Chair Ford, we have 7 members present. I believe we need 10 for a quorum, so we do not have a quorum at this time. I see Assemblywoman Thomas is now present, or I'm going to call the members who I see. Assemblywoman Thomas, are you present?
Here.
And Christine Payson.
Here.
So I believe we're now at 9 and we need 10.
Okay. Thank you for that. I think, do I have my DAG?
Yes, you do, Rosalie Bordelove. I'm on Zoom.
Hey, Rosalie. So without a quorum, I know we can't do any action items, but can I do anything else?
You can still receive presentations if you would like to receive presentations. You know, anything that is done, it doesn't count as a meeting right now. So
Okay.
you can discuss, you can receive presentations, but you can't take any action.
But I think the key phrase you said is that it doesn't count as a meeting.
Correct.
So why don't we wait a minute to see if we can get a 10th person in. And we will circle back either in 10 minutes or when we get a 10th member, whichever comes sooner, okay? Everybody just take a break until you hear us call you. All right, we're gonna come back real quickly and go ahead and ask for the 10th person's name.
Okay, do we have Chelsea Cheatham present?
Present, yes.
Okay, Mr. Attorney General, we have a quorum.
Okay, I hope I didn't lose anybody. I know I said 10 minutes until the next 10th person came, but whichever came earlier, that's what I said. So we now have a quorum and we shall proceed with agenda item number 2, which is public comment. For discussion only, public comment will be received in person either at the location here or above, also via Zoom. Do we have anyone present here for public comment? Or anything anyone wants to add here? All right, what about up north? Anybody up north for public comment?
No one in Carson City, Mr. Attorney General.
Okay. Anyone on the phone for public comment?
I don't see anybody raising their hand at this time.
Anyone on Zoom for public comment?
No, sir.
All right, we will
Also,
close public comment.
Chair
I'm sorry,
Ford?
go ahead.
Rosalie
Yes.
Bordelove here. I just was gonna, a quick point, because we have the new requirement from AB 219. If we could have, or like someone read just instructions for how to call in and make public comment, since this is the first public comment period.
No, I don't.
In case we have anyone listening in.
Oh, it's on there, so I'll read this. If you are dialing in from a telephone, dial 719-359-4580. When prompted, enter the webinar ID, which is 841-1615-6896. Then enter the meeting passcode, 676-835. And then please press *9 so the host can prompt you to unmute. If you're joining virtually with computer audio, please use the raise hand feature to indicate you would like to provide public comment so the host can prompt you to unmute. Before commenting, please state your full name for the record. And comments can also be emailed to allhale@socialent.com. These comments and questions will be recorded in meeting minutes. Thanks, Rosalie. All right, can I proceed, Rosalie? I'm good now?
Yes, you may. Thank you for reading that.
Thank you. All right, with that, we'll move on to agenda item number 3, which is a review and approval of the minutes from April 5th, 2023. And this is for possible action. You have been distributed those meeting minutes, and take a couple seconds, but I will entertain a motion to approve the minutes or to amend them as necessary.
AG Ford, I see that Christine Payson has her hand.
Christine Payson has arrived or has her hand raised? Okay, go ahead, Christine.
Thank you, Chair. Christine Payson for the record. I think this is the appropriate time for me to do this. It's referenced the presentation I gave in May about possibly using some of the funds for a partnership with public health for a overdose response team linkage to care. And I believe it's slide number 8, there's a one-word change I'd like to make because it says funds to start up and continue to support the program, but it should have said a program because no program actually exists yet. So it's just a word from the program to a program.
All right, thanks for that, Ms. Payson. Duly noted. Any other changes before we entertain a motion to approve as amended? All right, seeing none, I will entertain that motion. Can someone make a motion to approve as amended?
Dr. Dixon, I'll make a motion.
Dr. Dixon has moved. Could I get a second, please?
This is
Anybody?
Shayla Holmes, I'll second.
Thank you so much. All right, it's been moved and properly seconded that we approve the meeting minutes as amended from April 5th, 2023. Any discussion? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Any opposed, say nay. Any abstentions?
Stephanie Woodard. for the
Motion carries
record,
unanimously.
I'm abstaining.
Oh, thank you. You got that, Dr. Woodard. All right, thanks so much. Motion passes. Moving on to the next item is approve updates to the bylaws, agenda item number 5. Dr. Kearns, Mike Shores.
We're on 4.
We're on 4. Oh, my bad. Reappoint surge members who are legislators. Not quite reappoint, but to welcome you back. We know our legislators have put in yeoman's work over the course of the last 6 months. Thank you so much for your work and dedication to the state. I know Assemblywoman Thomas is on the screen now. I don't know if you have any others right now. So thank you so much for your work, Assemblywoman Thomas. Welcome back. And we welcome you back to your subcommittee as well. Treatment and Recovery Subcommittee. So stay tuned for information on that. And with that, is there anything further need to say on this?
We also have a legislator going to prevention subcommittee? No.
They were both previously on the prevention.
Okay, then we're good.
Okay. All right. Thanks so much. Moving on then, agenda item number 5, approval updates to the bylaws. Dr. Kearns, go ahead.
Yes, thank you. You all received copies of the current bylaws, and I also pushed out to all the committee members the last bylaws. So if you wanted to do comparison, just some general comments. First of all, thanks to our DAGs who assisted with the revisions that you see. They did a lot of work on these to help us to get them in the format you currently see, which are significantly smaller than they were previously. One of the things that you'll note is where we had language from NRS previously, what was put in was the actual reference to the NRS. So you would then need to go to the NRS to see that language. But that was probably the biggest change. And then where we had working group, we changed that to the Substance Use Response Working Group, or the SURG, throughout. And those were really the major changes that we made. So if anyone has questions or comments.
All right, we'll open the floor for questions or comments before we entertain a motion to approve the bylaws, the updated bylaws. Any questions or comments for now? I don't want to move too quickly because I know we may be lagging in response time. But I hear and see none. Therefore, I will entertain a motion to approve the updated bylaws.
So move.
Who is that?
Clara Thomas, so move.
All right, it's been moved by Senatorwoman Thomas. Can I get a second?
This is Jessica Johnson for the record. I'll second. the
Jessica Johnson has seconded it. It's been properly moved and seconded. Therefore, we will open it up for discussion. Any discussion on this? Hearing and seeing none. All in favor, say aye. Aye.
Aye.
Aye.
Hi.
Any opposed? Oh, thank you. Any opposed? Any abstentions? Motion carries unanimously. Thanks so much, everybody. Moving on then to agenda item number 6, an update on opioid litigation, settlement funds, and distribution. And I believe we have our colleague, Mark Kruger, on the screen. And Mark, we'll give you the mic, sir.
Hi, General. Hi, everyone. Thank you very much. Mark Kruger, Chief Deputy Attorney General. I have a very, very short update. I was able to get out of the office for a little bit, but Terry Kearns told me I had to be here at this meeting. No, in her defense, she also said I could send somebody, but I didn't have anybody to send. So let me make it quick for you guys, and then I can go back to enjoying my wonderful beach that I've been having a great time at. I'm trying to make you all jealous. So,
And you are, so don't be rubbing it in. Mark.
Okay, yeah, no, good. I'm glad. Okay, so I don't have any chart to share, but I just wanted to let you all know that obviously we're at a point in the litigation where we're wrapping up. I'm very pleased to echo General Ford's comments or his press release that we have recovered $1,129,855,634.24. That is a total amount that goes both to the state and all the other signatories to the One Nevada agreement. And then for Nevada's share, let me just get to the right number. Nevada will see $438,279,584.74 out of that. Now, that's still only an estimation because there's still fee funds and some other cost fund applications that we're making, which should bring that number up. In addition to that, the endo bankruptcy, we don't have any numbers for that, and eventually we will. And so these numbers will still change a little bit. Also, General Ford and I spoke about creating some charts, which will actually reflect all of the different amounts for each of the signatories. We're in the process of doing that. Please be patient. It does take time to get completed. And with that, General Ford, I can entertain any questions, or I can call it a day.
Well, you're not calling it a day yet. I'm gonna find some questions just because you're trying to make us jealous. No, I'm just joking. Hold on one second, Mark. Any questions anyone have of Mark for now?
I do.
Yes, Jessica Johnson, go ahead. And then we'll come to you, Debbie, in a second, but go ahead, Jessica.
Thank you so much. Jessica Johnson for the record. Mr. Kruger, don't want to keep you too much from your vacation. I was curious if you could speak to the folks who are the other signatories, particularly like the counties and cities that were on there. Are those amounts being dispensed annually or as the litigation comes in to the office? If you could speak to that, please.
That's a great question, Mark Kruger for the record. The amounts as they come in will then be dispensed. It takes a few days for us to get them out, but it all goes by wire, so it's actually really pretty quick once they're dispensed. In addition to that, and the amounts come in at varying times, and that chart's going to reflect when they come in. So a lot of settlements come in July. Some settlements come in December. Just depends on what payment schedule each settlement is on. In addition to that, there is going to be increased reporting. The last report covered the period of time of the previous year, so you don't see much because we'd just gotten in money last December, and so all of these local signatories and even the state hadn't had an opportunity to get their plans done and actually start funding services and programs. Now that the money is coming in and they're actually starting to fund services and programs, the next year's report, which we hope to have right around February, is going to be a lot more full. It'll have a lot more data and information on it so people can see the results of what's actually being funded. I know that was more than your question, but it triggered in my mind that I should also provide that information.
Thank you.
Thank you. Ms. Nadler.
I think he might have answered my question. Again, Debbie Nadler for the record. So as far as the money that we have used so far, or that we've allotted or given so far, is there, or is this what you're talking about, that you're going to make a list of the actual entities or where each dollar has gone to? Or is there already a list so we can see, 200,000 went to this entity, 100,000 went here? Is that what you're talking about when you say you're going to put up a list, or is there already one?
Mark Kruger for the record. Yeah, basically there's mandatory reports under each of the settlement agreements and underneath the bankruptcy. So the state is being the point of contact, and I don't want to step into this too much because this is actually the expertise of Dawn Yohe, who I believe is going to be presenting as well today. She's the one that handles and has really been doing a yeoman's job of managing all of these reporting. And if you look at the Fund for Resilient Nevada website, that's where we have all the acceptable uses up there from every settlement. It breaks it down by settlement. She's got the reports that have already come in and the compilation of that report. I don't know exactly how that looks and how it will continue to look. It may change a little bit, but she has broken it down by categories. So, and I see Dr. Woodard's hands up, so I will turn it over to them gladly because they are the experts in this area.
Well, before we turn it over to her, I want to clarify something. Let me be very clear. The Office of Attorney General, my office, Mark Kruger, what he does, it is not to divvy up per recipient how much money they've gotten, unless that recipient is a municipality that is a signatory to the One Nevada agreement. So, Ms. Nagler, I'm making up a number here. Say we got $10 in and Nye County got $1. That's what we're going to show. We're not going to show how Nye County spent that $1. We're just going to show that Nye County got $1. It is not incumbent upon my office to delineate how the recipients of the funds that the Advisory Committee for Resilient Nevada or whomever else gives money to. It's not incumbent upon my office to produce a list showing how they spend it. And so if that is a expectation, I want to distribute everyone on the screen of that right now. You will not be receiving from this office a delineation per entity of how that money is spent. We will, however, break down how much every signatory, which are the counties and municipalities, has received from the monies that we brought in. Does that make sense, Ms. Nadler?
Yes, sir. Thank you so much for explaining that. And I understand it's not your office, but I guess is the ACRN or the DHHS,
Exactly.
Will they be making the list of exactly where each dollar has gone? Will it be transparent for Nevada to see?
Thank you for that. So then I will defer to Dr. Woodard, whose hand is up on this.
Thank you, Stephanie Woodard, for the record. So I think it's important to clarify again how the money flows. I know Mr. Kruger's done a lot of work with the SURG in the past to help to understand how the dollars are actually coming in and how they're dispersed. So when the dollars are going to the local jurisdictions, there is required reporting that they will need to provide on where those dollars are going. And that is actually in accordance with the legislation that established the Fund for Resilient Nevada and for the One Nevada agreement. So that information will be available as those reports are coming in and as those monies are dispersed. I believe that's on an annual basis. And then there is information related to the allocations of funds from the Fund for Resilient Nevada. And I believe Don Yohe is on the call today and we'll be going over some of that. So whenever there is an opportunity to bring transparency to the distribution of these funds, there will absolutely be efforts made, not only to have it posted, but to bring that information to groups such as the SURG to make sure that you have the information that you need as part of our fulfillment of the legislation. One other thing that I was just hoping Mr. Kruger would be able to speak to is the disbursements of the funds, because many of these settlements are not coming in one lump sum, but will actually be provided over the course of several years. So I don't know, Mr. Kruger, if you could speak to that just a little bit so that there is an understanding of the cadence in which we will be receiving these dollars.
Yes, absolutely. Mark Kruger for the record. So you're correct. And General Ford absolutely makes a great point that the money that comes in is money that we've received as part of settlements in this opioids litigation or through the bankruptcy courts. When the money comes in, we allocate it to the different signatories to the One Nevada Agreement. At that point in time, our responsibility towards those the funds are done, and we turn it over to DHHS, who then, as Dr. Woodard indicated, it then does the reporting. And you are correct, Dr. Woodard. And just so everyone is clear, the charts that we're putting together will have an estimated time frame of when all of those payments come in. For example, Walgreens is a 15-year settlement. It will have payments that come in over the course of 15 years in December. So that just gives you an idea of how they kind of break down.
Thank you. And on that point, I don't think I see your hand up, Assemblywoman. I'm coming to you in just a second. I just want to highlight something that Mark failed to say at the very beginning. He gave you the cumulative 1.1 billion, but what he didn't say was his work to help bring in $285 million 2 weeks ago. I think we just announced. Maybe it was last week we announced from Walgreens, and that is essentially the last settlement from this iteration of litigation, absence of bankruptcies, like he said. But $285 million was the last number that we just announced with Walgreens. That brings the total that this office has brought in to over $1.1 billion. And it will come in over the course of the next, I would, roughly say 20 years. And it just depends upon when the settlement, what the settlement contract says about disbursements, to your point. So anyway, I wanted to say thank you, Mark, for all that work you've done and working with outside counsel, ensuring that we've done the very best that we could in this regard. So thank you for that. Let me move over to Assemblywoman Thomas.
Thank you, AG. And I also want to iterate thanks to your office and all the people, your team that has accumulated these settlement funds. My question actually has to do with interest. And, because when these funds are coming in, there will be an, into the banks and interest. Where would that money, is there a hold? Is that accounted for in the estimate of all of these millions of dollars that have come in for the settlement?
Well, that's a great question, not one that I contemplated. And I can say that the numbers they've given you do not include whatever interest may accumulate, although I'm not even sure how that's going to operate. So let me give it to Mark to see if he has an answer. And if he does not, Assemblywoman will have to search around and figure out what the answer is. Go ahead, Mark.
Thank you, General. Mark Kruger again for the record. I do have an answer. That's a great question. And
of course you do.
General Ford is absolutely correct. We did not estimate an interest amount on those funds. The state's portion of the money that comes in pursuant to the legislation that was adopted in 2021 now, that legislation requires the state's portion of the funds to go into an interest-bearing account. So they will be earning interest, and that money should be added to the total. So we'll get with the HHS to determine how much that is, and we can add that periodically to our chart.
Great. So thank you. So it seems like we'll be gaining additional funds from just the interest alone.
That's correct.
Thank you.
Thank you. Any final questions on this before I let Mark go ahead and get back to his vacation? Mark, just so you know, I haven't had a vacation yet. I'm just saying, and I don't have one on the horizon either. I'm not even quite sure how I let you on vacation. In fact, I might need you to come back early just because I don't know, I'm gonna make up something for you to do. How about that, Mark?
You were feeling rather generous, I think. You were happy about everything. So anyway, thank you all. I really appreciate it. I do enjoy coming in and updating you guys and appreciate your questions.
Thanks, Mark. Have fun, man. We'll talk to you later.
All right, sounds good. Take care.
All right, moving on. Agenda item number 7. Okay, Fund for Resilient Nevada update for information and discussion. Danielle is on the line and we'll give you the mic.
Thank you. Good afternoon, Chair and members of the committee. My name is Dawn Yohe. I'm a clinical program planner with the Department of Health and Human Services Director's Office, overseeing the Fund for Resilient Nevada, which is the state's portion of the opioid settlements. Do you have my slides in here, Kelly?
Yeah.
There it is. Yay.
Yes.
Okay.
Yeah, we
So
have.
next slide.
Kelly Marshall for the record. Yep. They're right there.
Thank you. Next slide. So just a little bit of background, Nevada Revised Statutes 433.712 through 433.744 established the Fund for Resilient Nevada in 2021. One of the Department of Health and Human Services responsibilities is to develop a statewide needs assessment as well as a statewide plan to drive funding allocations. The needs assessment was completed in July of 2022, and then the plan was finalized in December of 2022. I have provided a link there directly to the plan. NRS also created the Advisory Committee for Resilient Nevada to identify and prioritize recommendations to the Director's Office by June 30th of each even-numbered year. Their report is linked here. Next slide. A report regarding findings, recommendations, and expenditures is due on or before January 31st of each year to all of the following entities. That report is also linked here. Next slide. We did have to do some opioid fund mapping before we developed the plan. And so this is more of a high level of some of the opioid funds that are throughout the state, or substance use funds. And so these are not just specific to opioids, but I just wanted to give you guys a broader knowledge of, hey, there's other substance use funds that are kind of going towards opioids, or they are going towards opioids. And so you have the Substance Abuse Block Grant, which is $20 million per year for 2 years. It's not opioid specific. You have the State Opioid Response Grant, which is $16 million per year for 2 years with no cost extension options. And then you have the Comprehensive Opioid Stimulant and Substance Use Program, which is the COSUP grant. It's a little over $5 million for 2 years total. We have our Overdose Data to Action State grant. They just reapplied and asked for a little over $2.6 million per year for 5 years. And then we have our Overdose Data to Action local, which is housed at Southern Nevada Health District. That average is around 2.3 million. I think they've asked for more per year for 5 years. I also went ahead and added the Medicaid numbers that we've spent on substance use between July 1st, 2021, as well as through June 30th, 2022. As you can see here, the fee-for-service opioid use disorder expenditures, substance use disorder expenditures, as well as the MCO expenditures. The statewide plan goals were broken out into 7 goals. So goal 1 was to ensure local programs have the capacity to implement recommendations effectively and sustainably. Goal 2 is to prevent the misuse of opioids. Goal 3 is to reduce harm related to opioid use. Goal 4 is to provide behavioral health treatment. Goal 5 is to implement recovery communities across Nevada. Goal 6 is to provide opioid prevention and treatment consistently across the criminal justice and public safety systems. And then goal 7 is to provide high quality and robust data and accessible timely reporting. Next slide. These are, I know it's really small, but we have put a table in here of our current awards. As you can see, we have linked the awardee, the amount that they have been obligated, some notes on how that awardee is going to be using the funds, the location of service, as well as how it links back to the state plan goals. Down at the bottom, you can see that there's a little bit of a section that says awardee is goal 1, 2, 3, and 4. Those haven't been identified yet because either the funds are going to August IFC for approval or we're waiting for the MSA vendors to close through purchasing. The next slide, we are still contracting with Mercer. We worked with Mercer in order to provide, to help us with the needs assessment as well as the state plan. We're also contracting with Mercer to provide technical assistance to any counties, tribes, regions that reach out and are requesting technical assistance. So far, we have been working with, or we have heard from, Carson City, Churchill, Elko, Humboldt, as well as Nye. We're anticipating the following counties will also need assistance: Lander, Pershing, White Pine, Eureka, and Lincoln. On the next slide, Douglas, Lyon, as well as Washoe County have already completed their assessments as well as their plans. Story County's is complete, but is not approved by their commission yet. Mineral County reports that they are almost done. Esmeralda said that they might just incorporate into Nye. And then Clark has let us know that they have many needs assessments that have already been completed, and so they're going to be working off of those. Mark mentioned a little bit earlier that we did send out a reporting tool to all of the signatories of the One Nevada agreement for the calendar year of 2022. We were able to get 20 responses. Here's everybody who responded to that report. The ones that are not highlighted, they have not used any of their funds, and they are not sure which direction they're going to be going with their funds at this time. The ones who are highlighted in yellow, they have some intent to use funds, and we have that on the next slide. And then the ones that are in green, they have started using some of their funds. And then this is the reported uses as well as the intent. As you can see, Henderson as well as North Lyon County report some use of their funds. And then the rest of them, you can see that they haven't spent any money, but here's what their intention is to do with the money. And with that, I will take any questions.
Thank you for the question, for the presentation. I do have a question. I want to flip back to the awards slide. I guess it's number 16 in my packet. I don't know if that's what. Yeah. Well, based on what you presented to us, I guess 2 slides back, where you detailed the opioid fund mapping and where we're getting CASA funds and other funds. I just want to know which funds are those that are funding the awardees listed on number 16, or are the awardees all receiving these funds from the opioid settlements?
All of the awardees on page 6 are receiving opioid settlement dollars.
Okay, all right, that's what I wanted to know. All right, very well. Okay, that's all I have. Any other questions from anyone? I see a hand up in Carson.
This is Shayla Holmes for the record. I have a question for Don. I guess more of a clarifying point, that the information in regards to the signatories who have reported, that information was as of 2022 at the point of that reporting. So there is potential that individuals or some of those entities now have a plan or now have expended some of those dollars. Is that correct?
This is Dawn. Dawn Yowie for the record. Thank you for your question. Yes, that's correct. So the reporting period was a calendar year from January 1, 2022 through December 31st of 2022.
Thank you.
Thanks for that question. Any other questions? Debbie, I see your hand up.
Thank you very much. Okay, so I'm sorry, on page 16, those awards, those are from the opioid lawsuit awards, and that's going to be for June 2023 to June 2024. And this is what's been allocated already or given to them already.
Don Yohe for the record. These are executed awards. So these are dollars that if they haven't been executed yet, they're executed as of July 1st, 2023 for the fiscal year 24.
And this comes from the opioid lawsuit, correct?
Correct.
Or no? Okay, thank you.
Correct.
Thanks, Debbie. Any other questions? Yeah, go ahead, Jessica.
Jessica Johnson for the record. Hi, Don. Thank you for your presentation. I had a question about slide 19, the One Nevada Agreement reporting. If you can clarify, are these just from the localities where you received responses, not an exhaustive list of all funded entities, or is this a list of all entities and you received 20 responses of this list?
This is just the individuals that responded to the reporting requirement. So we sent it to all of the One Nevada signatories. We got 20 responses.
Thank you. And do you have off the top of your head, sorry, Jessica Johnson for the record, do you have off the top of your head how many 20 responses out of what total?
I do not, but I can get that for you.
Yeah, I don't remember how many signatories are to the One Nevada Agreement. It's certainly the 17 counties, right?
Correct.
And then we have some cities and maybe even other municipalities that have sued that are part of it. So I don't know the number off the top of my head either.
Perfect. Thank you.
Any other questions from anyone? Going once? Going twice? All right, thanks so much. We really appreciate that, Don. We'll move on then to agenda item number 8, legislative update. Ms. Hale.
Thank you, Chair Fort. So if you can go to the next slide, you'll be able to see, well, maybe it's a separate document.
It is.
Oh, thank you, Crystal. Thanks. So basically at the beginning of this session, we just did a search on bills that were related to substance use and pulled those out. So mostly for work in the subcommittees so that they could see kind of the progress and relevance to the SURG. And so those are the notes that you see in red under relevance to SURG are just explaining what recommendations they were affiliated with. And then it also links back to the legislation, AB 374, Section 10 requirements. So that detail, all of the subcommittee members have seen previously. There's an updated status at the end there showing which ones were approved by the governor. So you can see that first one, SB4, expanding allocation Fund for Healthy Nevada for grants. That was approved by the governor on May 29th. And as I'm going through these, there are probably folks in this on the SURG and certainly legislators who will know more about these. And so certainly feel free to offer any clarification or additional details as appropriate. We did kind of a short abbreviated referral on these. So then on SB 35, changing the penalties for fentanyl trafficking. And I know AG Ford, you will know all the details on this. But one of the things that was pointed out to us was that the main thing that changed was the minimum number of grams that would be considered trafficking, and that's 28 grams. AG Ford, I don't know if you want to add anything to that now, or if you want to go back afterward.
Why don't we let you finish and I'll go back afterwards.
Okay, on SB 117, expanding Medicaid coverage to community health workers, that was approved on May 29th. Next slide, please. And then SB 119 extends coverage for telehealth services. That was approved May 29th. SB 128 clarifying certification for community health workers. No further action was allowed after April 15th. SB 191 expanding Medicaid coverage to behavior analysts, assistant behavior analysts, and registered behavior technicians for recipients under 27 years of age. That was approved on June 12th. The next one, SB 197, no further action allowed on that one. Next slide, Crystal. SB 242 authorizes clinical trials with adults using MDMA or psilocybin in the treatment of mental health and other medical conditions. I know that Dr. Dixon followed this very closely, and she indicated that even though it was approved by the governor on June 12th, it was amended to really just create a study group. So kind of limited action on that one. SB 267, no further action was allowed on that one. Same on SB 377, down to SB 412. Appropriates $500,000 for the purchase of 2 machines that are capable of testing for fentanyl and its derivatives and measuring the concentration thereof. So I know there was a presentation to the SURG members on this, and so that was approved by the governor for funding on June 12th. Next slide, please. AB 37 supports workforce development for behavioral health care. That was approved by the governor on June 15th. And then AB 45 supports workforce development for healthcare providers through loan repayment. That was approved by the governor on June 9th. The next one, AB 69, that did not go through any further consideration after being referred to the Committee on Ways and Means in April. And then AB 115, no further action allowed. AB 132 requires the establishment of a regional opioid task force in Clark County. That was approved by the governor on June 5th. And Lisa Lee had pointed out the original bill was for a statewide committee, but this, as it went through amendments, it was just a regional task force in Clark County. AB 137, this bill expands confidentiality of reporting on fetal alcohol spectrum disorders, which may not be used for criminal prosecution. That was approved on June 9th. It did limit state funds allocated for Medicaid coverage for fetal alcohol spectrum disorders. And there was a note that DHHS would determine if federal participation is available through Medicaid. And others may be able to add to that one. On AB 115, go back one. AB 115, no further action allowed. AB 132 requires the establishment of a regional opioid task. Oh, I'm sorry. I got a little bit confused there, Crystal. It looked like we flipped one and then we went back one. So if you can go down to the next slide again. Sorry about that. AB 138, expand the state plan for Medicaid to cover evidence-based behavioral health services, approved by the governor on June 12. Limited funds were allocated through amendment. I think that's the last slide in that report. Oh, AB 156, ensure availability of medication-assisted treatment in jails, detention centers, and correctional facilities for people diagnosed with opioid use disorder and continuation of treatment on release or transfer, approved by the governor on June 15th. The division may use gifts grants to purchase opioid antagonists, and pharmacists were authorized to assess, prescribe, and diagnose MAT drugs under certain conditions. Next slide. AB 277, DHHS endorsement for rural emergency hospitals to serve as crisis stabilization centers, providing behavioral health services, leveraging Medicaid payment source. And that was enrolled and delivered to the governor on June 9th. It may have since been approved. I haven't been back to check on it, so other folks may have that information. AB 403, removing the requirement that such a halfway house be licensed by the division while preserving the requirement to be certified by the division. That was approved, and Lisa Lee noted that the language halfway house was updated to be recovery house, which is consistent with program administration. And next slide. Oh, AB 135, no further action allowed. So I think that now is all of them. And so back to you, Chair Ford.
Thank you for that summary. This is a very handy chart there. I can just real quickly speak to SB 35 and answer any questions that may arise out of it. It was a labor of love, to be sure. It was initially introduced, and I tried to remind folks that maybe Claire Thomas has a different experience, but I don't recall ever a bill being introduced in the same form that ultimately passes in. It's always an iterative process, and this was no different. We introduced SB 35 with low levels, as low as 4 grams being sufficient for purposes of trafficking, and through the conversation with people from this committee and others, we ultimately landed at a compromise where it's 28 grams now. 28 to 42, I believe, is low-level trafficking, and 42 and above is not high-level trafficking. And in addition to that, we added some requests from the recovery community that now require jails and prisons to offer medicated-assisted treatment in there as well. Part of the conversation around this was resulted in the governor appropriating $500,000 to buy new machines for being able to measure the amount of fentanyl in products, because the conversation was that you never really know how much of a fentanyl is in a product, because they just say if it's 4 grams, whatever it is, if it has a trace of fentanyl, the whole thing was attributed to fentanyl. And so there was a lot of discussion around all of that, and it ended up here and ultimately was approved and signed by the governor. We think it's a good step forward to address trafficking. And there's a key distinction here. We tried to make it a point to say this doesn't talk about mere possession of fentanyl. Because of the conversations around those who may be suffering from use disorder or whatever the case may be. We don't want to get them wrapped up in a war on drugs, a new war on drugs, similar to what we saw in the 80s and the 90s. And so possession is already addressed in the statute elsewhere. This deals with trafficking, and we tried to make that point known. Are there any questions anyone has around SB 35? That's probably the only bill that I can specifically speak to. If you have questions about others, we can see if there's anyone else who can address those. Cool. All right then. Any questions, generally speaking, about this part of the presentation before we move on to the next agenda item? Yes, ma'am.
This is Dr. Dixon for the record. It isn't in this list, and I think it was from SB or AB, but it was the Kratom bill.
The which bill?
Kratom bill.
Okay.
They wanted to make Kratom kind of like marijuana, and they wanted to have all these regulations about growing and packaging, et cetera, and we don't want it anywhere. So the bill passed, but the governor vetoed it. And several of us wrote letters to the governor to encourage him to veto it.
It was part of this list that we.
No,
different. Oh, okay.
But Kratom, they like to kind of make it look like Kratom is just a lovely little herb to smoke. Kratom is an opioid agonist, and people get addicted to it, and they overdose and die on it. So
wow.
We wanted, a lot of us wanted to be put on the schedule, Schedule 1, but the industry is too powerful. They've got convinced the Board of Pharmacy not to do it yet.
Well, that's interesting. Thank you. I'm going to actually get the bill number from Terry and take a look at that, because I don't think I'm familiar with it. So thanks for mentioning it out loud.
It was our big bill. The Psych Association, we fought this one.
Okay.
And we have been fighting it for a long time. And the Medical Association, they joined us. And, but the industry just doesn't, they don't want us to say it's an opioid, but it is.
Okay.
By definition.
All right. Any other questions or comments about agenda item number 8?
Debbie Nadler.
Yeah, Debbie, go ahead.
Sorry, I just wanted to make a quick comment. I absolutely agree about the Kratom. My son took it I know so many people who took it did bad things. It was almost, it was opioids. It made him crave it even more. And I wholeheartedly agree. It is in every 7-Eleven. It is in every tobacco shop. I have been purposely going in there, and it absolutely, we have to, 5 states, maybe 7 now, have outlawed it. So 100%. Thank you. Just wanted to give my comment on that.
Thanks, Debbie.
The feds have not outlawed it, though. That's the problem. We can't get the DEA
To move on, huh? Okay. Is there another hand up? Assemblywoman, go ahead.
And thank you, AG. Assemblywoman Clara Thomas for the record. Excuse me. I just wanted to, because I put it in the chat, that AB 277 was signed by the governor on June 15th, and that's just for the record.
Thank you. I'm sorry, I have to remind us, we can't speak in the chat though, because of public record, open meeting law stuff. So thanks for mentioning it out loud, okay? Any other questions or comments from anyone else? Okay, seeing none, we will move on then to agenda item number 9, subcommittee reports. Beginning, we will have to, this time we have prevention, treatment and recovery, and response. And so we'll start with prevention. Jessica Johnson.
Thank you so much, Chair Ford. Jessica Johnson for the record. The prevention subcommittee comes to the larger surge today with a preparation of 2 reports, one from our prevention subcommittee, and then we'll follow up with some workshop recommendations from the harm reduction meeting that I believe was in April. Before I begin, I just wanted to say a thank you to my fellow prevention subcommittee members and to Emma Rodriguez from the SEI staff, who is SEI staff to the committee. Couldn't bring any of this today without the support of those folks. So thank you all so much. On your screen here today, you'll see just a brief summary of the history of the prevention subcommittee meetings, the presentations that we've received and the dates that we've received those for the record. These have been instrumental in informing the recommendations that we're bringing forward today that are in development from our subcommittee. So this is our March, April, May meetings, and then our June meeting as well on the next slide. Any questions from those, or Ms. Rodriguez, is there anything you'd like to add as staff to the subcommittee? All right, wonderful. Fantastic. So on the next slide is the current recommendations of the prevention subcommittee. Chair Ford, I wanted to mention at our, I believe our January meeting, you had encouraged subcommittee members to entertain recommendations beyond opioids, right, as that was a key task of the surge and the legislation, and our committee really took that to heart. So I wanted to just reflect that here today. So I'll walk the committee through these recommendations. So the first recommendation centers on a recommendation to DHHS or whichever entity oversees the funding that would be appropriate for this. The committee wasn't entirely sure who that entity would be, but to double the amount of investment in primary prevention programming every 2 years for ages 0 to 24. The rationale for this came from, we had received multiple recommendations for specific programming and programs, and the surge prevention subcommittee wanted to really keep a statewide focus. So as we discussed more in our committee, we came to the consensus of really needing to reach saturation for young people in Nevada when it comes to primary prevention programming, looking at evidence-based or community-based evidence in order to reach all young people across Nevada in those pieces. What we heard from prevention experts across the state was that there are really small scale things that are working very well in multiple jurisdictions, but opportunities to scale that up was important to the committee. So this is currently the recommendation that we're workshopping around prevention funding. Would you like me to take questions or present them all, sir?
Go ahead and present them and then we can
Okay,
take
terrific.
questions.
All right, so recommendation number 2 out of our subcommittee is around increasing support for youth vaping prevention. We're actually hearing a presentation on this from a statewide subject matter expert next week. So I imagine that we'll have more robust and concrete details to help support this a little bit more in depth. This came from some recent funding changes to statewide vaping prevention dollars, and wanting to hear sort of what the successes of those programs have been and how the prevention subcommittee might be able to look to that. And then the third recommendation is for DHHS, the Office of Analytics or appropriate entity, to create a data dashboard or other type of regularly updated report on alcohol outlet density. Alcohol outlet density, as we heard from presenters to our subcommittee, is associated with multiple adverse health outcomes and can often, alcohol outlets can often be co-located in neighborhoods that are predominantly communities of color. And so the subcommittee felt as an initial action item that we needed to better understand what these data look like statewide for their impact, and to utilize that data to help improve local or statewide policy change. So those are the 3 subcommittees that the prevention subcommittee is currently workshopping.
Thanks. The vaping one sticks out to me because I know our office participated in a vaping summit of sorts where we were able to fund some of that program. And I wonder, Teresa, I mean, TPT, I think you're on. Let's just note if we have anything further we can do on this particular arena to help fulfill this particular recommendation. I would be interested in the alcohol outlet density component you're talking about. I think anecdotally, you can probably ask anybody from particular neighborhoods what it looks like. It's usually a church and a liquor store right next to each other in many places where I know of. So I would be interested in seeing that as well. Any questions, comments, concerns, complaints around these recommendations? Dr. Woodard.
Thank you, Stephanie Woodard for the record. Jessica, thank you so much for the overview of all of the presentations that you've received. I'm interested in recommendation number 1 around the amount of investment in primary prevention programming every 2 years. I'm wondering if you have information currently on what the current investment looks like across all funding streams, both state general fund as well as grants. And what that investment has looked like maybe over the last 5 years. I know that there has been quite a bit of additional investment in primary prevention, and I'm wondering if that information is something that the committee already has or would be helpful to you in being able to both understand where the current dollars are being invested, and then what the pattern of investment has looked like to date.
Fantastic. Jessica Johnson for the record. Thank you, Dr. Woodard, for your question. I don't know that the committee has heard specific presentations on dollar amounts. As I mentioned previously, this was addressing sort of multiple specific program recommendations. But I will bring your point back to the subcommittee and work with staff to identify who might be able to pull a report like that together for further refinement of this recommendation. Thank you.
Thank you. Stephanie Woodard for the record. Attorney General Ford, if I may, one more comment.
Yes.
I think it would also be important to understand how these dollars actually come into the state and then how they are dispersed. There is a small amount of state general fund, but for the other grants, especially our substance abuse treatment and prevention block grant, there is a specific set aside for prevention, which is required to be 20%. The state continuously invests approximately 25% of that block grant. And I think that getting a baseline of all of the different funding streams, and if there are specific set asides, what those set asides look like can also help aid in this conversation, because for things like block grants, the state only gets their allotted amount, and that those dollars have to be spread across prevention, treatment, and the state chooses to allocate some of those funds towards recovery. And so for every dollar that gets shifted over and beyond that 25% that is already used, that would be a dollar that would be shifted from treatment to prevention. So I think it's important just to have a really a deep understanding of how those dollars are coming in, where they're coming from, and where there may or may not be a lot of availability of additional funds to continue to increase, especially doubling the amount of investment in primary prevention every 2 years. That may be a significant amount of money without additional appropriations coming in.
Jessica Johnson, for the record, thank you for that comment. Dr. Woodard, our prevention subcommittee, if appropriate, would love to reach out to you for maybe some recommendations for follow-up presentations to further refine this piece and to also, you know, support whichever entity is appropriate to help identify additional opportunities for funding or what that might look like. So thank you for your comments.
Thanks, Doctor. Any other questions, comments on this before we proceed? Okay. All right, go ahead, Jessica.
Wonderful. Thank you so much. With that, I'm going to move on to the harm reduction recommendations on the next slide. Thank you. So as you will recall, we heard multiple presentations on harm reduction, I believe at the April SURG committee meeting. I'm going to turn this briefly over to Emma Rodriguez to just talk through kind of the administrative components that happened on the back end before the SURG received these for workshopping. Sure, thank you. Emma Rodriguez for the record. So you'll recall we all met in April with the full SURG working group. We heard from subject matter experts who were recommended by members of the SURG and presented on their own recommendations. The SURG then decided to issue a survey for members to provide their input on those recommendations. So we distributed that following the meeting. We received 9 responses back, which were then posted for the June prevention subcommittee. So that's the subcommittee met in June and considered all of the survey responses. Those are posted online if anybody wants to take a look. And what Jessica will be talking through next are the result of the subcommittee's discussion on the workshop recommendations, which took into account the responses from those who responded to the survey. Wonderful. Thank you, Ms. Rodriguez. Jessica Johnson for the record. Any questions on the administrative processes from anyone on the subcommittee?
Who's not? Go ahead.
Terrific. Chair Ford, Jessica Johnson for the record. I just had one quick question for you. I wanted to clarify if you'd like me to report out sort of where the prevention subcommittee is at in a similar format that we did before, or seeking feedback for additional workshopping on these recommendations.
I mean, what do you think would be most useful for you in your committee?
Fantastic question, Jessica Johnson, for the record. I'd be happy to share with the SURG Prevention Subcommittee or the SURG Large Committee today what the Prevention Subcommittee has come up with thus far. Okay. Perhaps if members have additional recommendations, we do have an agenda item on our meeting on Monday to take these back for additional workshop. And to incorporate the feedback. So okay. I'm happy to present them all and then perhaps take questions again as in the previous.
Oh, yeah.
Okay, terrific. Wonderful. All right, we can move to the next slide, please. All right, wonderful. So Jessica Johnson for the record, these are the the harm reduction recommendations. You can tell my head is in a few places today, as outlined previously. So the first one is with regard to the Bad Batch app. We recommended to pilot and evaluate the use of the Bad Batch app services in one of the behavioral health regions. Our committee had a robust discussion around evaluation of bad batch apps, and that no robust evaluation for the implementation of them nationally has been done to date. So we included an opportunity to rigorously evaluate the impact and reach of this specific app and to determine the effectiveness and next steps for potential expansion statewide. Then number 2, so this recommendation was to establish a statewide initiative for community drug checking that incorporates qualitative and quantitative drug checking and includes the following parameters. Working with harm reduction community to identify partners and locations to provide guidance and training, starting all sites with mail-based testing while piloting on-site drug checking and a subset of early adopters to refine implementation needs, to standardize the data collection, entry, mailing, testing, mailing, analysis, reporting as a best practice to make this transparent as possible, and then to articulate the principles and plans for what will happen with the data. The rationale for this recommendation are not only what was presented at the full SURG, but the SURG Prevention Subcommittee also received a presentation from Dr. Tracy Green at Brandeis University, who has worked on a multiple statewide initiative around community drug checking programs and incorporated that into the recommendations that are here. Number 3. So number 3 was related to expanding access statewide for harm reduction via shipping. We were a little challenged, I'll be honest, with this specific recommendation in terms of wording, but wanted to include what we had to date here. So what we were able to pull from this was around providing travel costs for the pickup of used products to be returned for destruction, to increase the advertising about the shipping programs to individuals who might benefit from these types of harm reduction supplies via mail, and to establish an alternative strategy if people aren't able to receive delivery of supplies for a variety of reasons. We know in many of the rural and frontier communities across the state that they may not receive any type of regular postal service from the major shipping entities. And so wanted to take that into consideration, as hopefully folks on the committee will have a stronger recommendation for framing around number 3. But this was what we were able to pull together from the survey responses and the presentation. Number 4 is around increasing support for harm reduction-based post-overdose outreach with public safety. The committee was aware of many post-overdose outreach programs statewide, and this recommendation, the adaptation of it was to either adapt or create additional harm reduction outreach programs that had a focus on public safety. So that had a focus on harm reduction and in their collaboration. So that's the difference here. And these included the multiple wraparound services that were presented to us during that subcommittee, including warm handoffs and the post-mortem services for families, if appropriate. Thanks for hanging with me, everyone. Next slide. You can tell we had a robust discussion.
It's where the work takes place. So,
absolutely.
Thanks for bringing it back.
Number 5 was around alternative pain treatment. Our committee felt this would be a better recommendation for the treatment and recovery subcommittee, and they have, since it aligns a little closer with their purview, and I believe they've agreed to take that on at their next subcommittee meeting. So thank you to the treatment and recovery subcommittee. Number 6 is around a bill draft request at the legislature to change the language around drug paraphernalia as it relates to smoking supplies. The rationale for this one was that in order to extend the scope of materials that are available for public health purposes at syringe services programs to reduce infectious disease and promote overdose prevention, the recommendation would be around this bill draft request from the purview and expertise of the committee. It would seem that a BDR is needed to modify the drug paraphernalia law for these specific items. So that was how we arrived at number 6 from the presentations that we received regarding the safer smoking supplies. And number 7, thank you for hanging with me, is around providing support to community coalitions to support community health workers, to expand harm reduction through the state of Nevada and prioritize funding for community health workers for community-based harm reduction services. Ms. Hale presented in the previous about the successes around community health workers, and so this would continue to expand access for these types of supplies and services into more rural and frontier regions in the state. That is the presentation I prepared on these, and thank you.
Great work. Like I said, these subcommittees is where the work takes place, and it's clear you guys put in some work over there. So thank you for that. We just finished legislative session, and we have a whole nother 18 months before we go back. But it is not too early to start thinking about bill draft requests. And just as I did before, if it falls within the purview of an AG BDR, I'm happy to consider reserving one in the event we need to find a place for it to land. So we also have 4 legislators on this thing, and maybe they can use one of the BDRs too. So we'll keep that in mind as well.
Thank you.
All right, thanks.
Do we have time for questions?
Yeah, we do. Do we have any questions, concerns, comments, complaints, whatever the case may be?
Dr. Dixon?
Dr. Dixon, yes.
Back to number 2 on harm reduction. Has your committee taken up this new drug,
Xylazine,
and taken that up into what we're going to do about that?
Thank you, Jessica Johnson, for the record. So, and this is regard to harm reduction recommendation number 2. So,
I think that's where.
Yes, Dr. Tracy Green spoke extensively about xylazine in her presentation to our subcommittee, and really the community drug checking program would look to her program is specifically talked about the qualitative testing that sort of happens on the ground in communities to let folks know all types of adulterants or additional additions that might be in whatever purchased substance that they provide. So that could include xylazine if xylazine were present, could include fentanyl if fentanyl were present, could include sucralose if that were present as well. And then her specific program then sends to a quantitative drug checking lab that's able to look specifically at what percentage of those substances are within whatever product was provided, if that makes sense. So while the committee didn't specifically look at xylazine, this type of a drug checking program would allow for the state to be ahead of any type of adulterant that might come up in any type of illicit substance.
That's a great question. And it reminds me, this is not under prevention or harm reduction, what I'm about to say, but it reminded me that Teresa and I, TBT and I, are going to be meeting with the Vice President of the United States next week to discuss fentanyl-based issues, and I'm confident that xylazine is going to come up in the middle of that conversation as well. Actually, I say it won't come up. It might, from a harm reduction perspective, TBT, maybe we mentioned that in the conversation with the Vice President. But in any event, I want to let you guys know that as well as a continuation of this conversation around opioids and particularly fentanyl. The current president, the current administration is working on that at the national level too. So go ahead. Yeah.
Jessica Johnson, for the record, I hope this is an appropriate comment here. And Dr. Woodard, if you have more to add to this, please hop in. But I want to say that Nevada was proactive in thinking about ways to support folks in our community to help prevent overdose. So in the 2021 legislative session, there was a bill that amended some of the drug checking laws. And I'm going to get this wrong because I am a public health expert and not necessarily an expert here. So maybe Dr. Woodard can hop in and support. But specifically what that did was allow for folks, individuals in good faith or localities like a syringe services program to support people to test substances to figure out what might be in them. Mm-hmm. And it was written broadly intentionally so we could be ahead of these different types of adulterants. And that so far from community members and advocates has proven us well that we're able to pivot as technology and as the drug market changes over time to help people make informed decisions and prevent overdose.
That's great. Great foresight. Okay, yes, ma'am. Dr. Kearns.
Terry Kearns for the record. I just was going to say on the harm reduction recommendation number 6 about the bill draft request to include smoking supplies and drug paraphernalia. I just listened in on a model legislation, and it was specifically for fentanyl test strips, but some of the states that have had good success have made some of their legislation generic to include things such as xylazine test strips and other things. So I'm happy to provide that information to you on that. That's one. Great. And the other thing I wanted to say is on the harm reduction recommendation number 7 concerning the community health workers. In some of the national meetings that I've attended, there's a great interest at the national level with what Nevada is doing in terms of community health workers. So I think this is an area we're leaders in and can hopefully push some of these as best practices for the future.
Great feedback.
Thank you, Dr. Kearns. I know Eric Schoen, who's on my subcommittee, will be thrilled to hear that. That is definitely an area of interest for him as well.
See, Carson City has her hand up. Go ahead, Carson.
Shayla Holmes for the record. On the point of recommendation number 7, I was just curious if the subcommittee had explored the conversation between community health workers versus peer support specialists and the different roles perhaps in the harm reduction, or what that could look like between those two different low-level supports that the states worked so hard to find funding for and certification of.
Jessica Johnson for the record. Thank you for your question, Shayla. We did, I believe someone asked nearly this specific question in our subcommittee. So good news on that front. We felt to offer sort of broad opportunities for navigators to help support people to engage with whatever part of the either the treatment, the harm reduction, the recovery system, supporting both peer recovery support specialists and or community health workers. There was some discussion about perhaps for some peer support specialists working in access to harm reduction or other types of programs might be potentially triggering in their personal recovery, or not something that is an area that they want to that they'd be interested in. So the committee in this particular recommendation was looking around community health workers, but would be happy to have additional discussion or opportunities with the treatment and recovery subcommittee to have a broader dialogue about how to increase these types of supports. But we really felt that some broad language around navigators and letting local localities within their capacities identify how that might be best supported was important.
Thank you. Any follow-up on that?
Dr. Woodard.
Not for myself, but I see Dr. Woodard has her hand up, so I'm anxious to hear what her thoughts were on the topic.
Likewise. Go ahead, Doctor.
Thank you, Stephanie Woodard for the record. So the state's actually done some work around this already, crosswalking the scopes of practice for both community health workers and peers. And there has been an effort to offer opportunities for cross-certification for peers who would also like to become certified as community health workers, and community health workers who also have lived experience to obtain the certification for peers. And I would say Sean O'Donnell at Foundation for Recovery is probably one of the more well-versed individuals in Nevada around how each of those scopes of practice can be leveraged really across treatment and recovery and harm reduction. So I would recommend reaching out to him if the committee needed a presentation or a subject matter expert that could speak to the nuances of both professions.
Jessica Johnson for the record, thank you for that recommendation.
Thanks, Doctor. Okay, any further questions, comments on this topic? All right, here's what we're going to do. We've been going for about an hour and a half, hour and 25 minutes. Why don't we take a 15-minute break and then we'll pick up after that to continue the rest of the meeting. Is that okay? Okay, so we'll see you back. It is 21. Let's see you back at 31, 36. Is that 15 minutes?
Yeah.
Yep.
Yeah, 36. See you back at 36, everybody. Thanks, y'all. Up for us. Reno up there?
Yes, we have Carson. Yep.
Okay. All right. Oh, Carson, that's what I meant. Okay, well, very well. Welcome back, everybody. Thank you so much again for being here. Let's move on to the next part of agenda item 9, which is treatment and recovery. And Steve Shell, you're going to be presenting for us today?
Yes, good afternoon, Attorney General. Steve Shell for the record. I'm Vice Chair of the subcommittee here today to speak for Chair Lisa Lee. The SURG Treatment and Recovery Subcommittee met on March 21st, 2023, and reviewed our areas of focus for SURG. We identified speakers and topics we would like presentations on. 2 presentations were provided on May 16th, as you will see noted. These were recorded and posted so that members and the public could review prior to the June 27th meeting. And I would like to note that one of our presentations was from Sean O'Donnell at Foundations for Recovery, and he has been very involved with us in helping us make recommendations that we are currently workshopping. At the June 27th meeting, Chair Lee summarized the recommendations and the Treatment and Recovery Subcommittee discussed the recommendations. The only recommendation in front of the subcommittee currently is item 1, which is to support prevention and overdose prevention outreach to underserved communities, including the BIPOC communities. Item number 2 was discussed at our June meeting, and the subcommittee is workshopping this to include all special populations defined by the SURG. The subcommittee discussed the opportunity for outreach to underserved communities, including LGBTQIA+ and BIPOC. They also discussed weaving in inclusion of innovative approaches to harm reduction by accessibility, such as vending machines and recycled newspaper boxes. We are also discussing ways to broaden recommendations beyond specific programs, which you see in the 2 bullet points under item 2. These will be discussed at our July 18th subcommittee meeting. The subcommittee also noted the opportunity to include recovery support services and weave in peers as a central component of service delivery to underserved populations, including train the trainer models and sustainability of these programs. So much more to come, and we should have more to report after our July 18th meeting. So I'll be open to any questions.
Thanks, Steve. Appreciate the presentation. Any questions of Steve? Listen, let me commend you all for having this focus on underserved communities. It's all the more important right now. I'm not going to get political, but there are efforts on the way to have a less of a focus on underserved communities. And this committee, at least under my leadership, won't follow that trend. So thank you so much for this focus, Steve, and understand that you have the support from the chair if you get into pushback out there in the community on these types of issues, okay?
Thank you, Attorney General. We appreciate your support.
Absolutely. Okay. What do we have next?
So unless there's any questions, we have the response.
Oh, okay, all right, very good. All right, my bad. Next up, we have Dr. Kearns with the response committee.
Thank you, Chair. For the response subcommittee, it will come as no surprise that our first meeting in March was to review our charge and our areas of focus, as with all of the subcommittees, and kind of just reorienting everyone and getting everyone back in the mode of starting the process that we had previously done again. And the April 19th meeting was an overview of our recommendations received and what our next steps would be. In our May 22nd, 2023 meeting, we had a number of great presentations. The first one was the opioid antagonist saturation plan that was presented by Morgan Green, who's a program coordinator with CASAT out of the University of Reno, Nevada, or University of Nevada, Reno. And a lot of great discussion came out of that and questions on distribution. For example, the fact that currently, just because our systems aren't really communicating well, that law enforcement's distribution to law enforcement, I should say, for naloxone isn't really captured in their plan. We also discussed whether we're getting feedback on the use of the naloxone that's distributed. And in some cases, it's self-reporting, so we don't often get great data on the use of it by the people who it's distributed to. Another topic was really how to distribute naloxone to our more rural and frontier communities, and whether that's through the vending machines or possibly even exploring using pharmacies for distribution because of naloxone now being an over-the-counter medication. So that was a great presentation by Morgan Green. Another presentation we had, which really this one is kind of a cross-cutting across all of our committees, but we took the charge on this one, and it's emergency department bridge programs. And what we found out is a number of things is that, first of all, oftentimes people who have overdosed and go to emergency departments, they're provided a prescription for naloxone, which most of the time does not get filled. So how can we better facilitate getting naloxone into our emergency departments so that it can be provided to the person without that prescription real time when they're being discharged? That was one component we talked about. Another component of it is the induction of buprenorphine within the emergency departments. So we've often talked about in many of our committees and other committees the fact that someone may be willing and ready to go to treatment, but they don't have a facility that has a bed open for them. So how can we better service our communities by having this buprenorphine induction in our emergency departments at the time when someone has overdosed? So Dr. Morgan from the Valley Health System down here in Clark County is really an innovator in trying to push this within the emergency departments within our state. And then also the question came up again for people who, okay, so you induce them in the emergency department, but they can't get into a treatment facility for days, having some type of a bridge again to get them through, and whether that's follow-up after discharge with peer recovery specialists and also community paramedicine who could actually provide buprenorphine or additional treatment until the person can get into a treatment facility. So again, a very eye-opening presentation that we had. We went back to our recommendations from our prior year from our annual report, and one that bubbled up that we said we really needed to do more research on was to resolve the conflict between the Good Samaritan drug overdose law and the drug-induced homicide. For those of you who don't remember, or probably it sticks in your head, that many people still have reservations or fear of calling 911 if they've witnessed an overdose out of fear of being arrested for that drug use and or for providing drugs to the person, versus that balance between our law enforcement trying to get drug supplies off of the streets. So we'll continue to look at this and see if there's any further research and action that we can recommend. Along those lines.
Let me chime in on that real quickly, because I know that, and maybe TPT, you can help me if I'm misremembering this, but I know that in our SB 35, our fentanyl bill, we extended the Good Samaritan law to the context of fentanyl overdoses or opioid overdoses. So I'm not certain if that covers what you're discussing here, or you're talking more broadly. And I could be misremembering, Teresa, but am I right about that?
AG Ford, you're correct. What we did was ensure that we kept the status quo language. And so when I was looking here at the Delaware language, I think what we want to do is compare, I think, the Delaware example to our example, or to our NRS, because our language, we have similar language where it talks about it's that the judge can take into consideration if the person took efforts to seek medical assistance, and that's kind of loosely paraphrasing. So I think what we can do is compare the two better. There's also the Rhode Island example. That's, I think, you know, if you have a continuum of how these statutes read, Rhode Island is certainly provides a pretty big shield. But I think that topic, that conversation is an important one.
All right, thanks, CBT. Go ahead, Doctor.
So thank you for that segue, which leads into the second recommendation, which Vice Chair Holmes brought up, and it's looking to revise our statute to include language similar from the state of Delaware or from Rhode Island as a possible model that we can work on. And to that point, at our next meeting, which is next Monday, we are discussing this topic and have asked some folks who were in on the conversations from SB 35 to be at that meeting to assist in that discussion as well. Our third recommendation is for substance use disorder, mental health, and medication for opioid use disorder, assessment, treatment, recovery support, pre-release case management, availability in incarcerated settings, implementation challenges and opportunities, and the 1115 waiver for Medicaid coverage 90 days pre-release, which I believe we're going to hear more about today. So that's our third recommendation we're looking at. And then the fourth from Vice Chair Holmes again is wastewater-based epidemiology for monitoring public health trends, which is currently being done, which had been done, for example, with COVID. So that's something that we will look. I know that both UNR and UNLV currently have the capacity to do these. So those were our recommendations. I'll take any questions or comments anyone has.
Any questions, comments? Go ahead, Jessica Johnson, and then we'll come to you, Ms. Nadler.
Wonderful. Thank you so much. Jessica Johnson for the record. Dr. Kearns, I wanted to just make add a comment, actually two comments on the opportunities to distribute naloxone in the emergency department. I guess this is a question. Does the subcommittee plan to or hope to entertain any type of recommendation from that presentation, thinking specifically about any of the barriers to implementation for that program?
Thank you for that question. That's a great question, and that's what we'll continue to workshop. One of the other things, we do have a presentation coming from the Board of Pharmacy because we want to know, what are the restrictions. And I'll give the example to everyone. For example, if you go to a hospital and you get an aspirin, which is over the counter, that usually comes from the pharmacy and has, all the procedures and policies related to pharmaceuticals. So how to make it better available to those who need it at the point at which they need it, and in the form in which they need it as well. So we'll take those comments back to the committee.
Thank you. Chair Ford, just one more comment, if that's all right. Jessica Johnson for the record. For your recommendation under review number 4 around wastewater-based epidemiology, if you're entertaining any additional presentations around this, I'd like to recommend Dr. Cassius Lockett from the Southern Nevada Health District, who's been monitoring this for public health, at least in Clark County, and might be able to speak and has been working with other jurisdictions who've also been looking at wastewater and can hopefully speak to some of the strengths and the challenges, particularly when it comes to opioids and opioid metabolites around this specific topic.
Great, thank you. I appreciate that. We'll likely be reaching out.
Thank you. All right, Ms. Nadler, and then Assemblywoman Thomas. Go ahead, Ms. Nadler.
Thank you, Dr. Kearns. Great presentation, great points. Could you go back, if you don't mind, to number 2? Under number 2, are y'all putting any other effort into advertising and letting people know that we do have a Good Samaritan law? Many people don't know about it. There are so many kids who get scared, as we all know, and ditch people. So how can we bring it to the public to let everybody know that that law does exist?
Great question.
Yeah, thank you. We hadn't considered that, but that's a great recommendation. And we have spoken about that and before is even education and outreach to law enforcement and making sure they're aware that we have the Good Samaritan drug overdose law on the books. So we'll take that recommendation into consideration. Thank you. Deb.
Thank you.
Yeah, that's a very good point. And you got me thinking, Debbie, on what my office can do to help on something like that. So thank you for mentioning that.
I have some ideas. Can I send you some
Okay.
information that other states are doing right now with it, if you don't mind? Thank you.
Yeah, absolutely. Through
Okay,
Dr.
thank you.
Kern?
Sure.
Yeah, thank you. Go ahead, Senator Thomas.
Thank you. Excuse me. Thank you, AG. And Assemblywoman Claire Thomas for the record. I just want to find out if you have a program that's linked in the courts, because I saw something earlier, I think it was number 3, as far as incarceration, you know, because I believe the courts have treatment and recovery management, and I was just wondering if this is also in the court system.
So I know that some of the specialty courts do have this, and I will ask Dr. Woodard if she has more insight into this. I believe this was Dr. Woodard's recommendation. If you can better address Assemblywoman Thomas's question.
Sure. So Stephanie Woodard for the record. The goal of the 1115 waiver for Medicaid coverage for 90 days pre-release is that there are currently federal prohibitions for Medicaid reimbursing services that are provided to individuals that are classified as inmates. So one of the biggest priorities of a waiver like this is to ensure that there is a seamless transition from the setting that the individual is incarcerated within to the community. And oftentimes that would require coordination with the courts, especially if the individual is being discharged to a treatment court. So it wouldn't necessarily be covered under the waiver specifically, but transitions of care are a large priority of a waiver like this.
Okay.
All right, thank you.
Thanks, Dr. Woodard. Any other questions from anyone?
I have a comment.
Yeah, go ahead.
Dr. Dixon for the record. The bridge program, I've been working on, we have a bridge program committee that meets quite regularly, although we're not meeting this summer. And Marissa Brown from the Nevada Hospital Association is kind of leading the charge on that. Well, one of the problems which didn't come up here in what your report was that physicians they're just not into it. It's just that, the prescribers, we don't have the prescribers with the dedication to do it. And I think that's one reason that they did away with the waiver back in December, is the hopes that more doctors would just start prescribing because they don't have to do this 8-hour training anymore. I think those of us who work in the business don't think that's going to really make any big difference. If they don't want to do it, they didn't want to do it, So it's a challenge to move prescribers towards being tuned in to substance abuse and trying to get them into treatment. And as I'm on the treatment committee, and I mentioned at the end of our last meetings that actually our treatment, all of us that do treatment, our numbers are way down now. People are just not coming into treatment now. I don't know what they're doing, but they're not coming into treatment. And I don't think it's just a referral issue. I think something else was going on. Jessica's got an idea.
No, sorry, Jessica Johnson for the record, just to comment on that. I was on a Big Cities Health Coalition call yesterday or last Friday, where they were talking about this nationally, that even in other cities, they're noticing the treatment numbers are down as well.
Yeah, I had a nurse kind of shadow me today from Phoenix, and she's with a program down there, and they don't have hardly any patients coming into treatment.
Well, thank you for your comments. It's something we hadn't really taken into consideration. That may be my naivety in it, but one of the thoughts was if we have some advocates that are doing it, such as Dr. Morgan, that perhaps that, you know, hoping she gets people to do it, and she does it and then gets other people to do it and so on and so forth, so.
Yeah, I know that the Right Valley was doing it. UMC was, I don't know if they still are, they had a program. Then we have other hospitals where the director of nursing has been known to say we don't have those patients here.
Oh, wow. Okay.
So we're up against kind of a.
It's ridiculous.
The whole issue of mental health and substance.
Dr. Kearns, thank you for the presentation, and thanks to all of the subcommittee report members and those who presented today. Very informative stuff. All right, we'll move on to then agenda item number 10, recommendation process, weighting and consolidating for possible action. Ms. Hale and Ms. Rodriguez, go ahead.
Thank you, Chair Ford. Laura Hale for the record. So you all will probably remember that in the last cycle, we went through a weighting process to prioritize the recommendations that you made. And it was mostly done through the subcommittees. Kind of each member would identify their top 5 priorities, and then they would discuss those within the subcommittees. And then those came forward to the broader SURG, and the SURG then voted on each of those recommendations that came forward, with the subcommittees limited, I think, to a total of 10 that they could put forward. And we got some feedback on that. So we wanted to offer some sort of alternative and maybe combined methods, because we just discussed this with Vice Chair Lisa Lee yesterday, and also with Dr. Kearns, so that we could present something to you for your consideration about how we might go forward. So just to quickly review the process that you used last year, you would look at all the recommendations that had been put forward through the members and then came into the subcommittee. You would be able to see what's part of section 10 under AB 374. That was your legislation that particular recommendation connected to. You could see what kind of cross-cutting elements there were. You could see what kind of special populations they served, but there weren't any specific weights that were assigned to those different areas that you were looking at. Instead, members would consider all of those things and individually decide, well, this is my top priority, or, you know, it's my 5th priority, or whatever it was. And based on that, we had predetermined weights that we would assign. So if it was a first priority, then that was worth, 50 points. And if it was a 5th priority, then it was worth, 2 points. And then those numbers would get added up for all of the members in the subcommittee, so you could see in the aggregate for the subcommittee what rose to the top of that level. And that was what was presented then to the full SURG. And then those recommendations were voted on. And so that went forward as part of the report. So a couple of questions were raised about that. One, people wanted members wanted for the SURG to have more opportunity to discuss those recommendations and how they went forward. There was a concern about how those came out in the report, whether they weren't necessarily identified in any kind of priority area. It also wasn't identified in the report that all of the members of the SURG supported a particular recommendation, or perhaps only some members of the SURG supported it. So we wanted to present an opportunity to add to this method so that you could engage on some of those items. So Crystal, if you could go back to the previous slide. This is based on, this chart is based on a method that Vice Chair Lee had used within Washoe County. And it's a little more objective, if you will, and we're calling this a criteria-based scoring. So it looks across different types of measures, and you would scale them from 1 to 5, which would be low to high. So kind of the reverse of the other metric we were using. So you'd look at impact, what is the magnitude of impact on individuals in Nevada for a particular recommendation? You would look at capacity and feasibility, whether there is currently infrastructure capacity, ability to implement that recommendation. You'd also look at urgency. There's imminent risk to and vulnerability of the target population, and there is an urgent need for implementation or expansion for people at risk to access the program being recommended. And then finally, equity. This recommendation advances health equity for individuals with barriers to accessing necessary or appropriate services. So we did just send this out to all the members yesterday, and we also submitted it for posting. We just had our discussion yesterday to figure out how to present this. So it may not be on the website yet, but it will be there soon, and all the members should have it. But it's basically allowing that more objective set of measures at the subcommittee level, because it's at the subcommittee level that you're having those presentations and having more in-depth discussions. So those members might have more ability to look at all these factors and weigh in on those. And the scores that you see in there are just examples based. We had to remediate this form. So originally it was comparing the two charts together based on a particular recommendation, but depending on which form you use, you come out a little bit differently. So the idea was that you could use this criteria-based scoring within the subcommittee, bring those recommendations forward to the SURG, as they collectively decide on what are their top recommendations based on this matrix. And then at the SURG level, all of the members would then rank based on their own background, information, interest, whatever, go back to that initial type of weighting to say, this is my top priority for those particular recommendations that were brought forward by the subcommittee. So in that way, all of the SURG members would have an opportunity to get into a little more of a discussion about those particular recommendations. So the subcommittees would present and talk about how they came to identify whether something was really strong in terms of impact, et cetera, to give people more of a flavor for that. And it's really up to the members, how you want to do this. We just wanted to be responsive to some of the feedback that we got about that process. And so this is basically what we have in mind. And it's not set in stone by any means yet. So we wanted to get your input, and I would certainly be glad to try to answer questions or comments or suggestions that you have.
No, listen, I appreciate that presentation, and it's great food for thought. I mean, look, I know SB 35, the fentanyl bill, is a prime example of how a discussion based on a different scoring criteria, so to speak, could have been helpful, because it was a recommendation out of this committee that we address the fentanyl trafficking stuff, but it wasn't unanimous, and so folks were making that point as we were having discussions on the bill over the course of the entire session, and it just would have been kind of good to be able to have a more robust understanding about how that weighted. But in any event, what are people's thoughts about this? And it may very well be that we have to have another discussion about it when, for example, some of the other legislators are here and when Lisa Lee comes back and some others. But are there any initial thoughts on this? Yeah, go ahead, Dr. Kearns.
Yes, thank you. The one thing that came to mind for me as I looked at this process is I like having the two-step process with more of an objective, and then it goes to all the subcommittee. But my only question for all of the SURG members to think about is, what about those cross-cutting recommendations, or like the harm reduction recommendations? Does the full SURG do the objective method for those cross-cutting or harm reduction? And then also, do the first method. We called it the scoring and the weighting. So the subcommittee is scoring them and then the larger surge is weighting them. So just want you guys to think about that because we do have, like I said, all of the harm reduction that was from the whole committee. And then we also have cross-cutting ones in, I think, probably all of our subcommittees.
Yeah, it's a helpful conversation again, because I view, as chair, I view part of my role as kind of advocating on behalf of the outcome of the committee's deliberations, the report, like a full-throated advocacy of essentially everything that we had come together on and had decided and put into this report, which probably wasn't what others were contemplating relative to how the advocacy would take place. And so it would be good, I think, for us to make a determination on how we're going to rank order these recommendations as they come out, and what type of advocacy is anticipated from those who get the ability to advocate or to push back on recommendations that come out. Go ahead, Jessica Johnson.
Yeah, Jessica Johnson for the record. As someone who asked for more clear scoring criteria, I just want to say thank you for hearing at least my ask. I hope there were others as well. Thinking specifically from a subcommittee perspective, which is at least where I feel like I can wrap my head around at this point, I do think this criteria-based scoring would be really helpful in those discussions, and in presenting the recommendations back to the SURG would also, as chair, give me some key points that that we could speak to. You know, that the committee rated the impact as a 5 because of blah, 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 blah would be a really wonderful way to be able to speak to why we're bringing particular recommendations forward, why they're framed in a specific way, or who the impacted populations are, et cetera, from that perspective. So I just wanted to say thank you for giving a little bit clearer scoring guidance, at least from the subcommittee piece. I think that component that I feel my initial thoughts prepared to speak to would be really helpful in guiding that process.
Okay, other comments on this? Frankly, I'm not quite sure how to proceed right now. This says it's for possible action, but I mean, is it ready for action? I mean, what am I doing now? I need some help.
Well,
I don't know. Go ahead, Laura.
I think we could just vote whether you want to pursue this sort of two-part process with using one tool at the subcommittee level and one tool at the SURG level. And then, you know, as the subcommittees use that first tool, they can give us feedback if they think it would be helpful to tweak this in some way. You don't have to make a final decision today, but it would be helpful to know for the subcommittees that are going to be meeting this month and next, if it's appropriate to go with that criteria-based scoring, because we've got to come back in October with those recommendations back to the full SURG. So we really want to be clear and transparent with members and the public about how we're processing this.
Yeah, no, that's a great point. So I won't suggest a particular motion. Instead, I will leave it to the committees and the members of this SURG committee to come up with a motion that you want to proceed on. And we will go from there.
AG Ford, if I could propose, and I'm not a committee member, so I'm not sure if I'm allowed to make a comment. I think it's up to you if I'm
Go
allowed.
ahead.
Okay.
Please.
I think what I heard Laura propose was almost like a motion to allow a pilot, or to allow some of the committees to try this. So therefore they could pilot it out and use it, and at their discretion, try it. And then when it comes back to the full committee, we can see how they used it, but we're not obligating any particular subcommittee to it. And I would think we would probably need a motion to allow them to do it this way, unless we can just kind of informally pilot without a motion. I guess I'll leave that to Rosalie, but Laura, unless I was confusing something, I think that's kind of what you were putting on the table.
Well, she's giving you a thumbs up, and that's why I love being on the committee with smarter people than I, because you've made it make sense to me. But I see a couple of hands up. First, let's go to Carson, and then to Dr. Woodard.
Shayla Holmes for the record. Thank you, Chair Ford. I think I was ready to make a motion, but I think with that discussion, I think we should decide to move forward today, given the time frame and when we need to come back with those recommendations. We've had extensive discussion in regards to needing to have some process or an enhanced process on how we came up with our recommendations from our last year's report. So I know Dr. Woodard has her hand up, but I would be ready to make a motion to adopt both criteria-based scoring and the weighted scoring as a whole today.
All right, let's put a pin in that motion. I just want to hear what Dr. Woodard has to say and see if it changes the way you want to phrase your motion. And if not, we will accept it and move on from there. Go ahead, Dr. Woodard.
Thank you, Stephanie Woodard for the record. I also just wanted to point out that this is a very similar scoring matrix to what was used in the opioid needs assessment and state plan. And so if this is the direction that the committee chooses to go, there's a fair amount of additional detail in the state plan that I think can help committee members really apply this criterion-based scoring with consistency. And I would take it a step further to say that if we decided as a committee that we would like some additional assistance in understanding how to apply the criterion-based scoring, Mercer worked on developing this matrix along with us and likely would be able to provide some basic level training for committee members so that everyone feels as well equipped as possible to be able to apply this matrix.
Very, very helpful. Okay, any more comments before I go back to Carson to see if she wants to articulate that motion? Any more comments, questions? Yeah, go ahead, Dr. Kearns.
I think, and this may be a second piece of it, is the decision by the committee on whether they want to score those cross-cutting and harm reduction as the larger surge, or if those stay with the committees they came out of, and then just weight them when they come. So that would be the second part of it. It may be two separate.
Can the part you just raised be brought up at the next meeting after the subcommittees have made, or does it need to be done right now?
Yeah, I think it needs to be done now because we need to know whether subcommittees do it themselves or they need to include the whole surge on those, like the harm reduction is the primary one.
Okay. Dr. Woodard?
Stephanie Woodard for the record. I would just suggest that if they are cross-cutting, that the subcommittees that those recommendations touch, members are offered the opportunity to also apply this rating, and then we can maybe pull people together to do consensus-based rating based on what those findings are. We have recognized time and time again that there are a number of cross-cutting areas that touch across at least two or more of the subcommittees. And I do think that it's an important opportunity for subcommittee members to have a chance to chime in and offer their ratings as well. That would just be my recommendation.
Okay, with all of that said, shall I go back to Carson and see if you are comfortable with what you've heard thus far and can articulate a motion that can be considered for a second and a vote?
I would still recommend a motion, or I would still make a motion, Shayla Holmes for the record, to adopt the criteria-based scoring and weighted scoring for the subcommittee and larger surge committee, with a process to be determined on how cross-cutting recommendations can be incorporated into that process without having a good way or recommendation on how to do that at the time.
Y'all so smart. That's cool. I could not have articulated that. Thank you so much for being on this committee. There's been a motion made. Can I get a second?
Stephanie Woodard for the record.
All right, I got Jessica Johnson beat you, Dr. Woodard. So we got the second from Jessica Johnson. Any discussion on this? Any further discussion? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Any opposed? Motion carries unanimously. Thanks so much. Okay, sounds like the subcommittees and the committee itself have a way forward on this. And thank you so much for your presentation on number 10. Do you have anything else, Ms. Hale, before I move on?
No,
No?
I'm all set. Thank you very much.
Right on. Okay, number 11 then, agenda item number 11, reconsidering prior recommendations. Dr. Kearns.
Yes, as you know, we made our report with our recommendations, and we had prior recommendations that may not have risen to our annual report. So the question came up about whether we should, or how we should reconsider prior recommendations. If it's a case that we just automatically pull those in, and, you know, I'll give the example of the waiting for fentanyl. That was one that went forward and has been adjudicated at that point, I'll say. And so do we need to follow it. And this recommendation came up because I know there's been a lot of prior work with community health workers and the status of community health workers, and probably to the point of a 10-year process for them. So do we make a recommendation, it doesn't maybe rise to the top, or it needs still rework, those sorts of things? So how do we want to go about reconsidering prior recommendations? And I know for myself, in part of the response subcommittee, we had the recommendation of the Good Samaritan law and the drug induced, and we just put it in again because we knew it still needed more work. I don't know that all the other subcommittees have done that. So I'll open it up for discussion and thoughts at this point, if that's okay.
Yeah. Yeah, go ahead, Jessica.
Jessica Johnson for the record. Dr. Kearns, this came up in the prevention subcommittee as well. Mr. Schoen's not here today, could probably articulate his much more well-versed than myself points on this. But even if there was an opportunity for subcommittees to consider, or the full SURG to consider tracking prior recommendations and to see if they needed some type of ongoing recommendations, many of the things that we're considering, as you mentioned, have been work that's been done in communities for a very long time. So I think the positive side of that means that we're moving forward things that are important in this work. And the challenge is that they probably need more than just a single year to consider, and, you know, waiting with sort of emerging trends or threats in that regard. So I don't specifically have anything, but this did come up for discussion in the prevention subcommittee as well.
Any other comments on this? I have a thought or two, but I want to open it up to others first. So it seems to me that there may have been developments subsequent to when these recommendations came out of subcommittee and made it to the big committee that may want to have a subcommittee reconsider whether those recommendations are still valid or if they are a higher priority at this point. Xylazine, I'm just making up something, right? Maybe that was something we didn't think about in the subcommittee as we were talking about a particular recommendation, and now it's out and maybe they want to reconsider. So maybe the option here is to ascertain from which subcommittee the recommendations came in the first place, send them back down to that subcommittee as they consider these other items that we're talking about, and see if they come back out. And if they come back out, then we can consider those along the same metrics that we just talked about in number 10. Does that make sense? Yes, ma'am.
Emma Rodriguez for the record. So I just wanted to clarify, are you suggesting that we take the annual report, look at all the recommendations that were in that 2022 report, send those recommendations back to the subcommittees they came from, and then the subcommittee would decide if they want to propose the recommendation again based on any progress that has been made?
Yes, essentially. Okay. I mean, I'm not married to the idea though. I mean, if someone disagrees, say it. Go ahead, Jessica.
Jessica Johnson for the record. There are a few specific recommendations that we, in the full SURG at the December meeting of last year, merged. So there are a couple of, to Terry's point about cross-cutting, that that may have 2 homes.
Okay.
So, but not the majority of them. So I think your recommendation for the majority of the recommendations is fitting. There may be a few that need
Go
some
to 2.
exceptions.
Okay.
Or go to 2 committees.
Any other thoughts on this? I'm just brainstorming here. Okay. Do I need to make a motion for that? Can we just send them back down? I need a motion. Okay. If no one else has ideas on this, or, I mean, we'll see if it dies. I'll entertain a motion to do what I just said. All you gotta say is so moved. I'm just saying.
It's a movement,
Okay.
Tom, so moved.
All right. Now I need a second. It could die for lack of a second too. I don't know.
Debbie Nadler for the record, second.
All right, thank you. Is it moving properly second to do what I said? Any further discussion on this? All right, all in favor say aye. Aye.
Aye.
Any opposed? Abstentions? Motion carries. Thanks so much. Hope that helps.
Yeah, that
Okay.
does. Thank you. That's very helpful.
Okay. All right, number 12, agenda item number 12, presentation on Nevada's treatment of opioid use disorders and substance use disorders transformation project. For info and discussion only, we have Sarah Dearborn from Social Services and Mike Shores, ma'am.
Great, thank you so much. I appreciate the invite to present to the SURG committee. So Crystal or Emma, do you have my slides or would you like me to? Oh, you've got them. Okay, great. Thank you. My name is Sarah Dearborn. I am the Social Services Chief over our Behavioral Health Unit at Nevada Medicaid, also known as Division of Healthcare Financing and Policy. Next slide. So I will do my best. I know it's nearing the end, and it's all Medicaid language, so I'll do my very best to make this as exciting as possible. But I will provide just a brief background on 1115s and this specific 1115 waiver, as well as some of the deliverables and kind of where we're at with our implementation plan and what the meat of the waiver really looks like. And then provide some additional next steps. Next slide. Great. So in response to the ongoing national opioid crisis, the Center for Medicare and Medicaid Services, also known as CMS, has indicated a willingness to provide additional flexibilities to help states improve access to and quality of SUD treatment through Medicaid 1115 demonstration waivers. So without an 1115 demonstration waiver authority, Medicaid currently is prohibited from reimbursing for services in what's known as an institution for mental disease for the Medicaid eligible population between the ages of 22 and 64. So this 1115 substance use disorder demonstration waiver, this option allows states to be able to test full coverage of SUD treatment service array. So not just your typical outpatient levels of service, but also those targeted residential levels of services that typically do qualify as what's known as those institution for mental diseases. So the authority that was provided to Nevada Medicaid to permit us to apply for this 1115, that was granted during our 2021 legislative session under Senate Bill 154. And last December 29th of 2022, Nevada finally received our application approval for this project, but it doesn't stop there. There's many other deliverables that I'll get to in a moment to actually get this implemented. Briefly, what this waiver will cover, again, those kind of residential levels of care. So we have our ASAM level 3.1, which is our clinically managed low intensity residential services. ASAM level 3.2, which is our clinically managed residential withdrawal management services. ASAM level 3.5, clinically managed high intensity residential services, ASAM level 3.7 are medically monitored inpatient withdrawal management. And then lastly, ASAM level 4.0, which is our medically managed intensive inpatient services typically provided within hospital settings. Next slide. So now that we have our application and our authority approval, now comes a lot more work ahead of us. So I'll talk briefly about our SUD implementation plan. The implementation plan provides kind of a framework for states to be able to document its approach to implementing SUD policies and develop strategic approach for meeting the milestones which reflect the key goals and objectives for this program. It also helps to determine appropriate information for the state to report to CMS in the quarterly and annual monitoring reports. Implementation of a substance use disorder health information technology plan as well, which describes technology that will support the aims of the demonstration. So we very excited to have received approval of that as of May 24th. So now that we have implementation plan approval, once that occurs, states are able to collect federal financial participation for these services. Whereas previously, even with just the authority of the application approval, we still had to go that extra mile and get the implementation plan approved. One of the next deliverables is the monitoring protocol. So this describes the state's metrics that will be reported to document what and how it plans to report to CMS on the quarterly and annual basis to demonstrate progress towards the 1115 goals and milestones. We were able to submit our monitoring protocol to CMS on June 12th, and that is currently under review. Hopefully we'll receive a pass or an A on that and be able to move forward. The next deliverable, which we're currently working on, is the evaluation design. So the evaluation design highlights key hypotheses, evaluation questions, measures, and evaluation approaches, which will provide for a rigorous evaluation of a SUD Section 1115 demonstration. The draft evaluation design must also include a timeline for key evaluation activities. This evaluation design is rather robust, but it is due to CMS on August 26th. This evaluation design helps support states for their independent midpoint assessment. An independent midpoint assessment is performed by an independent agency, so not Medicaid, to really evaluate on the progress of the goals and milestones within the 1115. The next deliverable I wanted to mention is the post-award forum. So these are to be held 6 months after our implementation plan approval, and then we hold them annually thereafter. This post-award forum gives the opportunity for the public to provide meaningful feedback on the process of the demonstration. In conjunction with the forum, the annual monitoring report will be made available for public review as well. So since our implementation plan was approved in May, we're shooting for an estimated November date for that post-award public forum. Next slide, please. Great, thank you. So I really wanted to kind of get into the meat of this waiver and what Medicaid is actually going to do. This particular 1115 is a 5-year demonstration waiver. So it gives us 5 years to implement all of these activities to achieve completion of these milestones. So there's 6 identified milestones. So I just wanted to give you a brief summary of the activities that will occur within each of these milestones. So the first milestone is access to critical levels of care for opioid use disorder and other substance use disorders. So within that 12 to 18 month time frame, Medicaid will be working on a state plan amendment to clearly define all of our substance use treatment services, whether that means really defining substance use counseling, because right now it's kind of encompassed under our mental health therapies. So we really just want to be specific about our substance use treatment services. We'll also be able to define these residential levels of care a little bit better in our state plan. And as a reminder to this group, a state plan, Medicaid state plan is our contract with the federal government, whereas Medicaid service manual policy is kind of is Medicaid's contract with the providers performing these services. Also within that 12 to 18 month timeline, we are planning to develop a new Medicaid service manual chapter for substance use disorder treatment. So currently our policy around substance use treatment services is located within Medicaid Services Manual Chapter 400, and it's an attachment to a very long chapter as well. So we thought for clarity, we would develop a brand new chapter. This chapter will be MSM Chapter 4100. And it will be very specific to substance use disorder treatment, because right now we hear from providers that it'd be helpful to have clearer policy. Are they intended to follow the policy that's above in Chapter 400 or within attachments B and C? So we think that this will support providers better. Within the next 24 to 36 months, we'll also do work around a state plan amendment that will redefine the reimbursement for residential levels of care. So we hear currently that our current providers that are performing these services, they're receiving a bundled rate through the substance abuse block grant. And so Medicaid would like to come along alongside that and be able to provide a bundled rate. Recognizing that residential services is really more of a bundled service rather than individual services. We are having some discussions around this right now as we prepare for implementation on how we can support providers in rolling this out and whether billing for individual services currently or a possible bundled rate will be possible at this time, but it may need to wait for 2 years down the road when we're able to receive that budget authority. Also within that 24 to 36 month period, our plan is to add pharmacists as eligible providers for medication assisted treatment. I know before you had mentioned some of the bills that you were tracking. This implementation plan was completed prior to the end of the legislative session. So the good news here is pharmacists were included in one of the bills. I believe it was AB 145. Or I could be wrong on that. So don't quote me. There's a lot of bills right now with Medicaid. So, but the good news with that is that bill authority will actually give Medicaid a quicker turnaround time to include pharmacists as eligible providers for medication assisted treatment. Let's see. All right, on the next milestone, which is use of evidence-based substance use disorder specific patient placement criteria. Within the next 6 to 12 months, we'll define our prior authorization requirements for each of these reimbursable ASAM levels of care. Also within the next 12 to 18 months, as I had mentioned before, that's when we're really doing a lot of work on our current state plan language around specific substance use treatment services. We will also leverage a lot of the work that we've done throughout our Support Act post-planning demonstration grant, activities to support growth within in increasing provider capacity at each of the ASAM levels of care. And then within the next 24 to 36 months, as I mentioned before, we're really going to work to redefine that reimbursement. So you'll see a lot of these activities may be duplicative within each of the milestones, but essentially a lot of the work we're doing, we're trying to be as efficient as possible in addressing as many milestones as we can with certain activities. Next slide, please. Okay, the next milestone is the use of nationally recognized SUD-specific program standards to set provider qualifications for residential treatment facilities. So within the next 6 to 12 months, our focus will be turned to our Medicaid Management Information System, also known as MMIS. And we are enhancing our system to be able to enroll substance use treatment providers that are licensed or certified as individual Medicaid providers. And we'll be able to link to a substance use treatment provider agency. So currently the way our system is built is our substance use treatment providers are enrolled as a group, and it really makes it difficult to capture efficient data on who is actually delivering services and what services they're delivering. So we're going to shift and develop a new provider type for our substance use treatment providers. Within the next 12 to 18 months, we'll be updating our Medicaid Services Manual policy to include the requirement of offering all FDA-approved MAT on-site or facilitate access to off-site MAT. So again, just strengthening some policy criteria to align with best practice standards. The next milestone is to build sufficient provider capacity at critical levels of care, including medication-assisted treatment for opioid use disorder. Within the next 6 to 12 months, we'll be integrating our intensive crisis stabilization services, which is a state plan amendment that's currently under review. But these services will be a new service delivery for individuals experiencing a mental health or a substance use crisis. So hopefully we'll be able to get approval on that very soon. We'll also be using our Support Act post-planning grant demonstration data, provider surveys, and enrollment information to identify specific counts of current providers performing and accepting new patients at all the critical levels of care. And then within 12 to 24 months, we'll further develop and refine our SUD data book developed through our Office of Analytics team. This was an activity we had within our Support Act grant, but as you all know, legislative session has kept us all very busy. So we're hoping to get back on track with implementing that SUD data book for awareness. We will also refine our data collection to be able to collect specifics on individually enrolled substance use treatment providers that are available in Nevada. Again, once we can get that new provider type and enrollment specialties developed. Next slide. Thank you. The next milestone is our implementation of comprehensive treatment and prevention strategies to address opioid abuse and OUD. So within the next 6 months, but throughout the life of the demonstration, we'll continue to work across the Department of Health and Human Services, across all of our sister agencies to support access, training, and awareness of coverage through increased provider communication, through Medicaid web announcements, and monthly substance use disorder treatment provider engagement meetings that we've been hosting. And then, of course, evaluate data dashboard capabilities. Within the next 24 to 36 months, we'll increase access to naloxone by adding pharmacists as an approved prescriber. Again, we'll be able to do that sooner, so we'll be able to meet that milestone a little bit sooner with the legislative authority that was just provided. The last milestone is improved care coordination and transitions between levels of care. So within the next 12 to 24 months, we're going to be redefining discharge criteria that's specific to our residential treatment providers, that's consistent across our Medicaid policy, as well as the Division of Public and Behavioral Health Division criteria policy. We really want to elevate and collaborate with our sister agencies so we're delivering the same messages. We will also develop Medicaid Service Manual and Division criteria standards for coordination of care for co-occurring physical and mental health conditions for residential levels of care, transitioning to outpatient levels of care. So again, with our upcoming Medicaid Service Manual updates, we really do want to emphasize to our providers the need for that necessary care coordination between these levels of care to support success of treatment. Within the next 24 to 36 months, we have in here, if provided legislative authority, integrate the collaborative care model within state plan and MSM. Again, this was written before our legislative session ended, and through AB 138, that bill supports Medicaid in integrating behavioral health integration services, also this collaborative care model within our state plan covered services. So we'll be working on that soon with all of our other legislative priorities. And then lastly, if provided budgetary authority, we plan to integrate a new target group for targeted case management, being our substance use disorder only target group. So currently our target groups for this population really is focused more on SMI. So we really wanted to do a substance use disorder specific target group. And then to support individuals that are transitioning between residential and outpatient SUD services. Okay, next slide. Thank you. So our next steps, we are working with our sister agency over at Division of Public and Behavioral Health, more specifically our SAPTA agency, on a timeline to transition our current IMD providers that are performing these residential levels of care, and transition them from billing the block grant services over to billing Medicaid. So we're still discussing steps for that. Also, we're working with our fiscal agent, that's also known as Gainwell Technologies, to ensure our Medicaid management information system and our billing is all reimbursable for SUD services that are performed in an IMD for the Medicaid population between the ages of 22 and 64. Because this was prohibited before the waiver, we had to remove some edits within our system to allow for billing to occur. Also, we will be taking our Medicaid Service Manual, Chapter 400, those where the substance use treatment provider services live, which is attachment B, C, and D. We'll be taking that to our July 25th public hearing. And the language in there, we really just want to align with the waiver authority. So any language that says we can't pay for services for substance use treatment in an IMD, we wanted to remove that. While we were doing that, we also wanted to remove some stigmatizing language. So you will also see a chapter change, or I'm sorry, a chapter title change, most likely. So we'll be changing anywhere it says substance abuse to substance use. We're also changing the words of detoxification to withdrawal management, and then removing any outdated or non-existent tools that were previously put in there long ago before we were able to do this chapter change. We will also be updating our provider billing guides to support providers in understanding how to bill for these services. And then all of this information, I've put the link or the hyperlink on this page, but we are trying to publish all of the necessary documents to be available to the public. So our implementation plan is on this web page, our application, even Senate Bill 154. Some of our public workshops that we did are all on this web page as well. And then lastly, we are working on creating an 1115 fact sheet to help inform on the specifics just for billing and performing services, just to try to have an easy document to read. We understand policy sometimes is not as easy to read, so we want to make this as helpful to providers as possible. And that concludes my presentation. So I'm happy to answer questions if there are any.
Sarah, thank you so much. We really appreciate the presentation. A lot of information in there. You clearly know what you're talking about, so good stuff. Questions from anybody? Yeah, go ahead, Jessica.
Hi, Jessica Johnson for the record. Thank you, Sarah, for a really robust and detailed presentation. I really appreciate learning more about the 115 waiver. I had a couple of questions. Was Nevada the first state to undertake this type of a 115 waiver to your knowledge? And what's the timeline? So I know that there's been a ton of work done in the approval processes. How long do 115 waivers last for?
Sure.
If you mentioned that.
Oh, sorry, go ahead.
No, go ahead. Thank you.
So Sarah Dearborn for the record, Nevada is not the first state. We're kind of coming in at the tail end here. I believe when we first started looking at these, I think 38 states have approved 1115s. So 1115 authority is interesting because many states, you can kind of build things that are not necessarily state plan covered services into kind of a packaged bundle and show the federal government, like, we can think really creatively and do a better job than what we're allowed to do within our state plan. So that's why there's so many deliverables included in 1115s, because we're proving to CMS that we can do this better pretty much. So there's about 38 states that have 1115s that include substance use disorder treatment services. This specific 1115 is solely for substance use treatment. Our plans for our future is we really do want to include the serious mentally ill population in this as well. But right now we're just trying to get our feet wet with the substance use treatment services. As far as implementation goes, so based on our implementation plan approval, that essentially lets the federal government be able to allow states to collect a federal financial participation dollars on that. So we're working on those system updates, and then with our sister agency, and we're hoping for a rollout of providers being able to bill for these services either in August, October. Again, we're kind of having those discussions right now. And as it's getting closer and closer, we have more providers reaching out and saying, whoa, what about this? And what about this? So we really just want to make sure that we roll this out effectively. So hopefully that answers your question.
Thank you, Jessica Johnson for the record. I guess my ignorance is the 115 waivers end. Is there like a end point, or is this something that that Nevada Medicaid will have in perpetuity?
Yes, I'm sorry, Sarah Dearborn for the record. This current 1115 is approved. It's a 5-year demonstration, so we are approved for this through December of 2027. States can amend their waiver, include different services, but then they can also apply to extend it as well for additional periods after that. So the first round is through 2027.
All right, thank you. I see Dr. Woodard's up, then I come to you. Dr. Woodard?
Thank you. Stephanie Woodard for the record. First, I just wanted to underscore the amount of planning and work that has gone into getting Nevada to this stage. Sarah and her team have been working for several years on developing the concept for the waiver and then moving forward with drafting the waiver. And then, as you saw, all of the work that has gone into getting the approvals and now getting through the implementation plan, the evaluation plan, and really rolling this out. So Sarah and her team deserve a huge amount of gratitude from Nevadans, because this is really monumental. I also wanted to just reiterate why this 1115 is so vitally important. And that is because up until the time that the services are reimbursable under the waiver, we have very, very limited funding to actually provide these critical levels of care. So we have our substance abuse block grant that is the largest payer for residential treatment services, and that block grant is incredibly limited. So we know that the need for years has exceeded our ability to actually provide access. And what this waiver is going to do is open that access. It will also provide funding for those of you who are familiar with the community triage center model. They previously haven't really had a pathway forward for sustainability for the withdrawal management levels of care that they are providing. This provides Medicaid reimbursement for that. There are some restrictions like room and board, which is why also the synergy between both Medicaid and the Division of Public and Behavioral Health is so important, because this really is a collaborative project between those two entities. But this really is a game changer for Nevada. We expect that this is going to really open up access to residential levels of care, as well as withdrawal management at the community level. So just wanted to put that out there for kudos to Sarah and her team, who have just done monumental work to get us this far.
Thanks, Doc. Yeah, I mean, look, this is remarkable. A lot of people don't know what's going on out here. People complain a lot about the state not doing X, Y, and Z related to whatever the topic is. In this case, substance use or opioid related stuff. And the truth is, there's so much going on. So kudos to you, Sarah, for putting this all together. And I appreciate the presentation. We have another question here from Dr. Dixon.
Yeah, Dr. Dixon for the record. Yes, we've been following the IMD problem for many, many years. And so it's amazing and wonderful that Nevada finally did something about it. And the question I have is, since we've had 38 states now have had waivers, and I don't know if there's any data that's been generated from that, but the question is, when are we going to just plain do away with
there you go.
IMD altogether?
Exactly. That's a federal question, I'm sure, though.
I have the same question. Thank you for the question. This is Sarah Dearborn for the record. I have the same question. If so many states are doing this, why do we even still have this IMD rule? It is a lot of work, as you've noticed, and thank you so much, Dr. Woodard, for that recognition. I definitely appreciate that. But it's a lot of work. It takes a lot of staffing time to implement these. So hopefully, moving forward, there's so much momentum around behavioral health services and really what states need, that hopefully we'll be able to do away with some, or make some changes around some interesting rules.
I think it's going to take legislative action, isn't it?
Congressional.
Congressional action.
Right. I mean, yeah. I suspect there's conversation with our national delegation, our fellow delegation, on these types of issues. And look, if 38, now 39 states do this, I can't imagine that there's not conversation going on around just repealing the restrictions in the first instance. But I don't know. Maybe we can ask our federal delegation or someone from their office to answer that question for us. Yeah, we'll follow up on that. Other questions? Yeah, go ahead, Jessica.
Sorry, Jessica Johnson for the record. Again, very detailed presentation, and this is totally my naivete about these types of processes. I'm wondering from the treatment side of the house, with the changes around telehealth for substance use disorder treatment, if that's included in this waiver or part of the work that you're doing as the implementation process moves forward.
This is Sarah Dearborn for the record. No naive question at all. Medicaid is very complicated. I think on your legislative bills, you briefly mentioned Senate Bill 119. That definitely supports the work around including telehealth service delivery. Medicaid, or Nevada Medicaid, actually has a pretty expansive array of what is able to be provided through telehealth. So that bill coming along, that will be more of our state plan. So it's not necessarily included within our waiver, but really open to all of our substance use treatment services, as well as our other mental health service delivery.
Okay. Yeah, go ahead.
Sorry. Thank you so much, Chair Ford. Jessica Johnson for the record. Sarah, I just wanted to mention, as someone who's proud to do this work here in Clark County and in the community, if there are strategies or ways members of this committee can help to get the word out about this to community stakeholders. You detailed a really robust plan for working with providers, but if there's a way we can reach folks who may be recipients of Nevada Medicaid to help to continue to educate about these types of services, at least for the SURG, as a SURG committee member, I'd be happy to reach out. I don't know if that's appropriate to say as part of the committee, but just to the point earlier about members of the public really wanting to know more or about this system, I'm happy to make those connections if appropriate or possible.
Yeah. All right. Sarah, thank you so much for spending your afternoon with us and presenting this important topic to us. This has been very informational, and I really appreciate that. So with there being no further questions on this particular topic, then we are about 4.5 minutes shy of our 5 o'clock hour, y'all. We're making some pretty good timing. Let's move on to agenda item number 13. Review and consider items for the next meeting. Dr. Kearns.
Thank you, Chair Ford. I would imagine that a good amount of time at our next SURG meeting is going to be the subcommittees presenting their recommendations and the justification with our new rating system for them. So I imagine that will be high on the list for topics. That's what I have. Emma, is there anything else that you have?
We do have that standing report out from Mr. Kruger, so I think that would be on there as well.
Okay. When is our annual report due? January what?
The end
January
of January.
31st.
End of January. Is this our last meeting coming up for the year? No.
We'll have one in December.
We'll have one in December so that we can, I'm just trying to remember how our timing of reviewing and approving the report before it goes out. Do we need a meeting again in December and in January? Or is it December that meeting where we're going to, how does that work?
Emma Rodriguez, for the record, I believe last year in December, we presented the draft annual report at that time, received feedback, and then came back in January to approve the report based on revisions made during the December meeting.
Okay. All right, very well. I mean, I think we need to keep that in mind, committee, that we're going to have to, oh, it's up here. There we go. That we're going to have to, okay, y'all got it all down. I'm just making it, okay. All right, never mind that. A topic that I'd like to have talked about maybe next year then at this point because of the importance of this last couple of months, emerging substance use issues. We talk about xylazine, like what else is on the horizon? I mean, what other substances are out there that, you know, and what are they called? I mean, what's the street name for, you know, xylazine, if there is such thing, that kind of thing. It's called train. See there? I didn't even know. So that's the kind of stuff. I mean, you know, so we can have a more colloquial conversation and be able to speak intelligently, at least personally, as we talk about this out there. So that's something that I would like to see on an agenda, maybe sometime in the beginning of next year. Okay. Any other topics?
I was going to say, along with Mark Kruger's update on the opioid litigation, if there's going to be an update from the Fund for Resilient Nevada, we might want to add that.
Okay. I would suggest if there are other suggestions, you can send them to Terry Kearns. You have other suggestions for topics. With that, let's move, I don't see any hands up. Let's move on to number 14 now, public comment. Do we have anyone here who wants to offer public comment? Yeah, Jessica?
Do you have to read out the public comment?
Oh, no, I've already done that. Oh, do I gotta do that again? Public comment shall be limited to 3 minutes per person. We'll begin with comments from Las Vegas and then invite, okay. All right.
You don't have to say it again if that helps.
Right on. Go ahead, Jessica.
All right, wonderful. Thank you so much. Jessica Johnson for the record. I have just 2 items here for public comment. The Southern Nevada Opioid Advisory Council, which is a local group in Clark County that looks to broadly address substance use, is having the 4th annual Southern Nevada Substance Misuse and Overdose Prevention Summit. Don't try to say that 2 times fast. That's happening August 10th in Las Vegas at the Red Rock Casino from 8 to 5 p.m. We have a really wonderful plenary speaker that'll be joining us from the Montana Institute, talking about community work. We're also proud to partner with with CASAT and the state around offering a training called SHIELD. SHIELD is focused on training focused for law enforcement and first responders on overdose prevention and safety. So if anyone is interested in attending that summit, you can reach out to Katarina Pulver at pulver@snhd.org, or myself, Jessica Johnson. My contact information is on the SURG website for anyone who would like to learn more about attendance. There are scholarships available to anyone interested, and if folks are hoping to attend the SHIELD training from across the state, there are travel scholarships available as well. So that's my first point. For public comment, my second piece of public comment, I hope I'm still on time, is a little bird told me that it was Dr. Stephanie Woodard's birthday today.
Happy birthday, Dr. Woodard.
I wanted to wish Dr. Woodard happy birthday and thank her for spending it with us.
Sure, that's right. Hopefully you about to go get some food now. It's been a long afternoon. Very good. Any other public comment down here? All right, any up north in Carson?
Thank you, Chair. No public comment in Carson.
All right. Any on Zoom? All right. Appearing not. Then very well. We are quite done. Thank y'all so much for coming out today. We are adjourned. See you next time.
Thank you.
Bye now.
So.